Ah, sugar. Oh, honey, honey. You are my candy girl, and you got me wanting you. Oh, honey. Oh, sugar, sugar.
Hello, hello. Happy Tuesday, friends. Sweetest of greetings. Welcome to our Panopto on hyperosmolar, hyperglycemic, non-ketotic syndrome. If you can't tell, my name is Galora, and soon you will hear the voices of Jasmine, Laura, Dayton, and Caroline. Let's get things started. In a healthy human, this cupcake, beautifully drawn by Jasmine, is eaten, and then it finds itself in the human's gastrointestinal system where it's absorbed. Now, we're going to talk about some of the pathophysiology and pharmacology involved in and that influence glucose absorption and levels in this human if they were unhealthy. Stay tuned.
We are beginning to see how the normal mechanism of glucose reuptake works. Insulin is released by beta cells of the pancreas, which is caused by the presence of sugars or carbohydrates that have been ingested. So in here, you see the glucose getting into the bloodstream and being introduced to insulin. They reach tissues via the blood and are able to enter the liver for storage as glycogen, other organs to be used, and muscle to be stored or used.
We want to show what is happening on a molecular level when we say insulin helps glucose get taken up in the cells because we want you to know how that actually happens. Once the insulin and glucose arrive at their desired tissue, insulin binds to its insulin receptor. What this causes for a vesicle containing the transporter for glucose, known as GLUT4, to fuse to the plasma membrane of the cell. Once GLUT4 is present in the plasma membrane, it serves as a highway for glucose to be able to enter the cell by not having to interact with the plasma membrane.
So, to give you a quick overview of the homeostatic state, we will follow this pathway. When the blood glucose level increases, the beta cells in the pancreas secrete insulin, which then lowers the blood glucose level as we've described before. If blood glucose level decreases too much, alpha cells in the pancreas secrete glucagon, which raises the blood glucose level. This is accomplished by glucagon stimulating glycogen to be converted into glucose in the liver and then released into the blood. Originally, the insulin is proportionate to glucose and binds to its respective receptor on a cell's plasma membrane. The pathology begins when insulin binds to the insulin receptor and GLUT4 doesn't get moved into the plasma membrane. Therefore, glucose cannot get into the cell and is forced to remain in the blood. Over time, we become glucose resistant because our beta islet cells become less efficient and endure the toxicity caused by the high blood glucose concentration.
Diabetes mellitus type 2 can be otherwise described as your body being very resistant to insulin. What happens is glucose is still transferred to the bloodstream once you eat, just like before, and insulin will still be released from beta cells of the pancreas into the bloodstream. The difference with type 2 diabetes and our previously shown normal pathophysiology is that on a molecular level, insulin will bind but not create the expected response, and glucose remains in the blood, just like you saw a moment ago. Since the blood remains at high glucose levels, beta islet cells will continue to secrete insulin. Therefore, the ratio of insulin to glucose is skewed, and you have lots of insulin in the blood while the glucose levels continue to be high. What you see in the diagram is mostly glucose left in the blood, and although this is exaggerated, essentially what happens with time is that beta islet cells get so fatigued that they stop making necessary amounts of insulin. Therefore, glucose will remain in high concentrations in the blood, and we become glucose intolerant. Fun fact, the glucose in high concentrations actually becomes toxic to the beta islet cells that are supposed to release the insulin, therefore damaging them even more. When dissecting the name of this syndrome, it is important to further understand the non-ketotic component of the name, and then we can piece the name together. As a patient who is hyperosmolar, hyperglycemic, you can be ketogenic or non-ketotic. In our particular case study, we are focusing on non-ketotic, but it is important to understand both. If you have diabetic ketoacidosis, then over time your pH level will be considered acidotic because our body has minimal glucose for energy and instead turns to using lipids, creating ketones. In our case study discussing hyperosmolar hyperglycemic non-ketotic syndrome, the body is not considered to be acidotic and within the normal range of 7.35 to 7.45. In hyperosmolar hyperglycemic non-ketotic, what is happening with insulin? Insulin levels are high enough to prevent lipolysis from happening, but are too low to prevent hyperglycemia from occurring. So, like I said, we have an excess amount of glucose in the blood, and this leads to glucose arriving at the kidneys in higher concentration than the kidney is prepared for. Therefore, glucose transporters of the kidney become saturated, and some glucose remains in the nephron's filtrate. Once upon a time, you used to be able to actually test for diabetes by tasting your urine and seeing if it was sweet. The consequence of glucose remaining in the filtrate is osmotic diuresis, which is the secretion of more water into the filtrate due to the hyperosmolar filtrate. Therefore, excess urination is happening. The aftermath of this occurring is that blood volume in the body decreases because of the loss of water to urine, therefore increasing the body's hyperglycemia. Our body doesn't try to compensate for the hyperosmolarity by releasing ADH, which causes water reuptake to occur. Ultimately, due to the high concentration of glucose, the product of the nephron will not be normal urine, but urine including glucose, which is also known as glucosuria.
So, why is it called hyperosmolar hyperglycemic non-ketotic syndrome? The person is becoming hyperosmolar because of the excess glucose in the blood. Additionally, due to some of the excess glucose not being transported back into the body as it should be, it remains in the filtrate attracting more water. Therefore, less water remains in the blood and more water is added to the urine. The person is also hyperglycemic because of the body's resistance to insulin. Insulin will bind, but the cell will not undergo any change, even though it should fuse the GLUT4 transporter into the plasma membrane so glucose can get into the cell. Instead, glucose must remain in the blood since it's too polar to passively move through the plasma membrane of the cell. Finally, non-ketotic means that the insulin levels are high enough that some glucose is getting into the cells. Therefore, the body is not forced to use lipids as its energy source, contributing a more ketoacidotic state.
Although our case study will explore specific drugs that our client is taking, for the current presentation we will explore insulin and anti-diabetic medications only, which are both treatment options for the management of type 1 or type 2 diabetes mellitus. However, it should be noted that insulin is not first-line treatment for type 2 diabetes and should only be prescribed if the client is significantly symptomatic or has significantly high blood glucose, which would be levels higher than 7.8 millimolars per liter or 140 milligrams per deciliter. Therefore, insulin is generally only prescribed in patients with type 2 diabetes that have exhibited inadequate glycemic control with lifestyle changes and oral medications. This is relevant for our case study because our client has come to the hospital with acute HHNS after long-term mismanagement of glycemic levels. In this particular case, insulin would be considered as an appropriate acute treatment for management of the symptoms associated with HHNS and for maintaining glycemic control long-term. Before we talk about the pharmacology available for type 2 diabetics, it's worth noting that the first-line treatment for type 2 diabetes includes individualizing glycemic goals, but also providing support and resources for dietary management, maintaining physical activity, and diabetes self-management skills. The Academy of Nutrition and Dietetics has made strong recommendations in which the benefits clearly exceed the harms for engaging in physical activity as a way to manage fasting levels of glucose in type 2 diabetics. The literature is in accordance with these recommendations, as studies have demonstrated that almost any type of physical activity facilitates glucose uptake, improves cells' insulin sensitivity, and aids in glucose homeostasis by lowering blood glucose for up to 72 hours post-exercise and improving insulin action. So over 150 minutes per week of physical activity is recommended, and with at least 3 days per week of exercise and no more than 2 consecutive days without exercise. So the extent to which insulin sensitivity is increased and how long fasting glucose levels are lowered really depends on the exercise duration, intensity, and then the subsequent food intake that someone has after exercising. Physical activity in combination with diet planning with a registered dietitian nutritionist also has a significant impact on diabetic management and is a strong recommendation. The diet planning should include macronutrient intake, portion control for weight loss, and healthy foods that are based around a Mediterranean diet. Ongoing lifestyle modifications can significantly improve clients' abilities to manage their diabetes without medications and prevent complications, including the one we're going to discuss for our case study, being hyperosmolar hyperglycemia. In this section of our Panopto presentation, I will provide a general overview of the pharmacology underlying insulin types, while also discussing the specific mechanisms of action of the various different types of insulin. So first of all, human insulin is a polypeptide hormone, and its primary activity is to regulate glucose metabolism. Insulin will bind to insulin receptors on muscle and fat cells, which are also known as adipocytes, and lower blood glucose by facilitating the cellular reuptake of glucose. Insulin will simultaneously inhibit the output of glucose from the liver. We will begin by discussing rapid-acting insulin, which includes insulin aspart, insulin glulicine, and insulin lispro. Rapid-acting works like regular insulin in stimulating insulin receptors on muscle and fat cells. However, these types of insulins have a DNA nucleotide or amino acid change to alter the final insulin protein structure. So, for example, insulin aspart has a single amino acid substitution at the 28th amino acid, so it's no longer a proline. And this basically changes the absorption rate of insulin in cells, leading to a faster onset of action and shorter duration, and also a longer extended period of action following subcutaneous administration. And the common side effects of this include hypoglycemia, weight gain, and symptoms including nasopharyngitis and upper respiratory infection. Also, lipodystrophy and dermatological reactions at the injection site include rash, can also result from the use of insulin. Short-acting insulins are the next type of insulin we're going to discuss and include regular human insulin, which is a polypeptide hormone structurally identical to the endogenous human insulin. Common side effects of using the regular human insulin include dermatological reactions at the injection site again, including rash, hypoglycemia, lipodystrophy, and weight gain. And our client is actually on Humulin R, or regular human insulin, and this will be further explored in the case study. The third subgroup of insulins include intermediate-acting insulins. In this group is included insulin isophane, which works similarly to regular-acting insulin as discussed above. The last group of insulins we'll discuss are the long-acting insulins, which include insulin detamir and insulin glargine. These work similarly and have the same mechanism of action as the human insulin, of course, so the way that they stimulate the muscle and fat cells in the body and decrease blood glucose. However, long-acting insulins have a more constant pharmacodynamic profile, so they don't have a huge peak in activity, and the insulin is basically, long-acting insulin is associated with a slowed systemic absorption and has a longer duration of action. Additionally, distribution to peripheral target tissues will be slowed because it can bind to albumin. Otherwise, it binds to insulin receptors and elicits cellular uptake of glucose the exact same way that the other insulins do.
Okay guys, I'll be introducing the oral antihyperglycemic drugs, which are usually added when lifestyle modifications have proved insufficient in managing high blood glucose and before adding injectable insulins. There are 4 major targets of action for these antihyperglycemics. 1, increasing the insulin secretion from the pancreas. 2, increasing insulin sensitivity of tissues. 3, lowering glucagon effect, thereby releasing less glucose from the liver. And 4, lowered intestinal glucose absorption. The biguanides include the most popular choice for first-line treatment of type 2 diabetes, the drug metformin. The mechanisms of action include increasing insulin sensitivity, lowered glucagon effect, and lowered intestinal absorption of glucose. So metformin does not directly cause hypoglycemia, which isn't a very attractive quality of this drug. It's also worth noting that this drug helps lower triglycerides and cholesterol, which will definitely prove to be pertinent in our case study. Some of the adverse effects include abdominal bloating and a feeling of fullness, nausea and vomiting, cramping, diarrhea and flatulence, and a rare but serious side effect called lactic acidosis, which is a buildup of lactate which can drop the body's pH low enough to be fatally dangerous. So all these symptoms are incredibly important to note. However, a patient can self-manage them in titrating up slowly and ensuring to take them with food. The next class includes the sulfonylureas, which mechanism of action involves retaining potassium inside the cells of the pancreas, which leads to the influx of calcium, which then pushes out insulin, thereby increasing the secretion of insulin from the pancreas. They are also known to increase insulin sensitivity in some tissues and may reduce the liver clearance of insulin. An important note with this class is that they are only really effective if the pancreas still has beta cell function. Some of the adverse effects include nausea, epigastric fullness and heartburn, weight gain, agranulocytosis, hemolytic anemia, thrombocytopenia, and cholestatic jaundice. Now, some of the interactions that are pertinent to our case that you'll see is alcohol will increase hypoglycemic effect, and thyroid drugs will minimize the effect of the sulfonylureas. The meglitinides has two drugs within the class that work identically as the sulfonylureas in increasing insulin secretion from the pancreas, repaglinide and neteglinide. One of the attractive qualities of these drugs is that there's less incidence of gastrointestinal discomfort. However, adverse effects still include weight gain, dizziness, and a potential risk of hypoglycemia. The thiazolidinedidones, or TZDs, have a mechanism of action which involves activation of the PPAR gamma receptor. The ligand for these receptors is typically free fatty acids signaling to ramp up fat storage in adipocytes, which effectively removes fatty acids from circulation, thereby increasing the demand for glucose in tissues. So while lowering triglyceride production, tissues were simultaneously sensitized to insulin. Some of the adverse effects include moderate weight gain, edema, anemia, increases in both LDL and HDL cholesterol, and osteoporosis. Now, one of the important notes for this drug is you'll need to assess liver function with ALT values for a couple months. The last class we'll include is the alpha-glucosidase inhibitors, or AGIs. Alpha-glucosidase is an enzyme in the brush border of the small intestine and works to break down carbohydrates into simpler sugars. When the enzyme is inhibited, glucose absorption is either delayed or outright prevented. Timing is important for the administration of this drug, and it's required to be taken with the first mouthful of one's meal. This prevents the glucose spike present when eating. Adverse effects of this class include flatulence, diarrhea, and abdominal pain, and one important interaction with AGIs relevant to our case study is with thyroid replacement hormones. Here's an overview of the tissues and targets where the drugs act on. Every tissue taking up glucose, as well as those organs of interest, include the pancreas, liver, and the intestines. The biguanides reduce glucose release from the liver, and both the meglitinides and sulfonylureas improve insulin release from the pancreas. The thiazolidinediones prevent free fatty acid release from adipocytes, and both the TZDs and biguanides improve glucose uptake by increasing insulin sensitivity at the tissues. Lastly, alpha-glucosidase helps prevent and reduce the glucose absorption following the chemical breakdown of carbs.
I'm back. Oh, honey, I'd like to commend you for making it this far and invite you to think with me for a second. We'd like you to consider and think about how unique of a condition hyperosmolar hyperglycemic non-ketotic syndrome is, and how there's just enough insulin to prevent ketoacidosis, but not enough to properly induce glucose reabsorption. We'd also like you to consider the role of lifestyle modifications in type 2 diabetes management, and finally, to maybe look into CAM therapies that can be used to manage hyperglycemic conditions. We'd like to thank you again for sticking around for so long. You guys are the sweetest. We will see you Thursday in tutorial. Thank you so much. Bye.